I want to talk to you today about a group of painkillers that occupy a peculiar middle ground in most people's minds: codeine, tramadol, dihydrocodeine, and the combination tablets that contain them, the cocodamol and codidramol, that a great many people take without necessarily realizing what's in them. These sit somewhere between the ordinary painkillers you buy freely and the strong medications people think of as serious. And that middle position is exactly the problem. Because they are opioids, the same family as morphine, they act on the same receptors and they carry the same class of risks, and yet they are frequently regarded by the people taking them as fairly ordinary tablets. And after 70, that matters a great deal because these medications behave differently in an older body. They are associated with falls and fractures, with confusion, with constipation that does not improve with time, and with dependence, and they appear on the international lists of medications to use with caution in older adults. Now, I want to be balanced from the outset because pain is real and undertreated pain is genuinely harmful, causing poor sleep, low mood, reduced activity, and the deconditioning that costs independence. So, this is not a video telling you that pain relief is bad. It is a video telling you what you are actually taking, how to take it more safely, and importantly, what the alternatives are, because for the chronic aches and joint pains that most older people are actually treating, these are not the best answer. So today, I'll explain what these drugs do and the important difference between codeine and tramadol that affects how well they work for you personally, the specific risks after 70, the constipation that is guaranteed rather than possible, the interactions that genuinely matter, the question of dependence handled honestly, the alternatives that work better for chronic pain, and how to come off them safely if that's the right decision. Let me begin with the mechanism. Let me explain what these medications actually are. They are opioids, meaning they act on opioid receptors in your brain, spinal cord, and gut, and their effect is not to remove the pain signal, but to change how your brain perceives and responds to it, which is why people often describe the pain as still being there but mattering less. And here is a crucial fact about codeine that a great many people have never been told. Codeine is what pharmacologists call a prodrug, meaning it is inactive as swallowed and must be converted by a liver enzyme into morphine, which is what actually relieves your pain. And the activity of that enzyme varies enormously between individuals for genetic reasons. Some people, roughly 1 in 10 of European descent and higher proportions in some other populations, are poor metabolizers who convert very little, which means codeine simply does not work for them. And if you have ever taken codeine and found it did nothing at all for your pain while making you constipated and nauseated, that is very likely the explanation. And it is worth knowing because it means codeine is the wrong drug for you rather than that your pain is untreatable. At the other extreme, a smaller group are ultra-rapid metabolizers who convert far more than expected and can experience dangerous effects at ordinary doses, including serious breathing suppression. Tramadol works differently and in two ways at once, partly as a weak opioid and partly by increasing serotonin and noradrenaline in the nervous system, rather like an antidepressant, which gives it some usefulness in nerve pain, but also, as I'll explain, gives it a specific and important set of interactions that codeine does not have. So these are opioids that change how your brain responds to pain. Codeine must be converted by an enzyme that some people barely have, and tramadol has a second antidepressant-like action that brings its own risks. Let me now go through the risks that matter specifically after 70. First, and most important in terms of sheer harm, falls and fractures. Opioids are consistently associated with an increased risk of falls and hip fractures in older adults, and they achieve this through several routes at once: sedation and drowsiness, slowed reaction time, dizziness, impaired balance and coordination, and confusion. And the risk is highest in the first weeks after starting or after a dose increase, which is exactly when people are least expecting it. Second, confusion and cognitive impairment, because opioids are among the medications most likely to cause or contribute to delirium in older adults, meaning acute confusion, and they contribute to the general fogginess and slowed thinking I described in my memory video as one of the reversible causes that must always be excluded. Third, breathing suppression, which is the mechanism by which opioids are dangerous in overdose, and while it is uncommon at ordinary doses, older adults are more susceptible, and it becomes a genuine danger in combination with other sedating drugs and in people with lung disease or sleep apnea. Fourth, nausea and vomiting, which is common on starting. Fifth, urinary retention, particularly in men with prostate enlargement, where opioids can precipitate the inability to pass urine that I described as a same-day emergency in my prostate video. And sixth, and this one is underappreciated, long-term opioid use suppresses hormone production, reducing testosterone in men and affecting other hormones, contributing to fatigue, low mood, and reduced bone density. So the main risks after 70 are falls and fractures, confusion, breathing suppression, particularly in combination, nausea, urinary retention, and hormonal effects with long-term use. Let me spend proper time on constipation because it is not merely a side effect. It is essentially a guaranteed effect, and it is handled badly. Opioids act on receptors in your gut wall and profoundly slow the movement of the bowel. And here is the crucial difference from other side effects. Most opioid side effects diminish as the body adapts over the first days and weeks, but constipation does not. The bowel does not develop tolerance to this effect, so it persists for as long as you take the drug, which means a person on regular opioids will be constipated for the entire duration unless it is actively managed. And in older adults, this is not a trivial matter because it leads to the impaction and overflow that I described in my constipation video, with the abdominal distension, loss of appetite, confusion, and the diarrhea leaking around a blockage that gets so frequently mistreated. So the rule, and it is a genuine rule of good prescribing, is that anyone starting regular opioids should start a laxative at the same time, not wait to see whether constipation develops, because it will. And the right laxative matters since a stimulant such as senna, often combined with an osmotic such as macrogol, is generally what's needed, whereas bulk-forming fiber laxatives are a poor choice in opioid constipation and can make things worse. And there are also specific medications designed to block the opioid effect on the bowel without reducing pain relief, which are worth asking about if the constipation is severe. So opioid constipation is guaranteed rather than possible. It does not improve with time. A laxative should start with the opioid rather than after it, and stimulant plus osmotic laxatives are the right choice. Let me give you the interactions, and here tramadol needs its own section because it is genuinely different. Tramadol raises serotonin levels, which means it can interact with a long list of other serotonin-affecting drugs to cause serotonin syndrome, a potentially serious reaction with agitation, tremor, sweating, a racing heart, fever, muscle rigidity, and confusion developing over hours. And the drugs it interacts with are extremely common: the SSRI antidepressants such as sertraline, citalopram, and fluoxetine, other antidepressants including mirtazapine and venlafaxine, triptans for migraine, and St. John's wort. So the combination of tramadol with an antidepressant is genuinely common and genuinely worth checking, and I mentioned it in my antidepressant video for exactly this reason. Tramadol also lowers the seizure threshold, meaning it increases the risk of fits, particularly in people with epilepsy, in those taking other seizure threshold lowering drugs and at higher doses. And it commonly causes low sodium hyponatremia in older adults, particularly in combination with diuretics or SSRIs, producing exactly the confusion, weakness, and unsteadiness that get mistaken for aging or for dementia. Beyond tramadol specifically, the interactions that apply to all of these drugs are these. Any other sedating medication, and this is the big one, so benzodiazepines and Z-drug sleeping tablets, which is the combination carrying the most serious official warnings because both suppress breathing and together the risk multiplies, along with sedating antihistamines, some antidepressants, and alcohol. Other opioids, including ones people don't recognize as opioids in cough medicines and combination painkillers. And a crucial practical one, paracetamol, because so many of these are combination tablets containing paracetamol, meaning that someone taking cocodamol who also takes plain paracetamol for a headache can easily exceed the safe paracetamol dose without realizing, which is a genuinely dangerous and entirely avoidable error. So, tramadol interacts with antidepressants, lowers the seizure threshold, and causes low sodium. All opioids are dangerous combined with sedatives and alcohol, and combination tablets create a real risk of accidental paracetamol overdose. Let me address dependence honestly because people are either unnecessarily frightened of it or unaware of it, and both are unhelpful. Three things need distinguishing. Tolerance means needing more of the drug for the same effect over time, which develops with regular use and is a physiological phenomenon rather than a moral one. Physical dependence means that your body has adapted so that stopping abruptly produces withdrawal symptoms, and this happens to anyone taking regular opioids for more than a few weeks, and it is not the same as addiction. Addiction means compulsive use despite harm, craving, and loss of control, and it is less common in older adults taking prescribed opioids for pain than in other populations, though it does occur. Now, here's the honest picture for the person watching this. If you have been taking codeine or tramadol daily for months or years, you are almost certainly physically dependent, which means that if you stop suddenly, you will experience withdrawal, meaning anxiety, restlessness, sweating, aching, insomnia, diarrhea, and a general awfulness lasting several days to a couple of weeks. And here is the trap. That withdrawal includes a temporary worsening of pain called hyperalgesia, so people who try to stop conclude that their pain has returned worse than ever and that they genuinely need the drug when in fact they are experiencing withdrawal. And there is a further finding worth knowing. Long-term opioid use can itself increase pain sensitivity over time, meaning that some people on long-term opioids have more pain because of the drug rather than despite it, and find after coming off that their pain is no worse and sometimes better. So, dependence after months of use is expected rather than shameful. Withdrawal includes a temporary pain flare that misleads people, and long-term use can paradoxically increase pain sensitivity. Let me now talk about what these drugs are and are not good for because this is the crux. Opioids are genuinely effective for acute pain, meaning a fracture after surgery or a severe short-lived injury, and for cancer pain and in palliative care, where they are invaluable. What the evidence does not support well is their use for chronic non-cancer pain, meaning the osteoarthritis, back pain, and general aches that most older people are actually taking them for, where multiple reviews have found modest benefits at best, no better than several non-opioid options, and diminishing over time while the harms accumulate. That is not a fringe view. It is the mainstream position that has emerged over the last decade, and it has changed prescribing guidelines internationally. So what does work for chronic pain in older adults? First, paracetamol taken properly, which means regularly at an adequate dose rather than occasionally once pain is severe, and with the dose reduced in people who are frail, of low body weight, or who have liver problems. Second, topical anti-inflammatory gels for joint pain, which, as I said in my ibuprofen video, deliver benefit locally with far less risk than tablets, and which have reasonable evidence in knee and hand osteoarthritis. Third, and most importantly, exercise, because as I've said repeatedly, exercise is the first-line treatment for osteoarthritis with better evidence than any painkiller and durable benefits, and physiotherapy for back and joint pain likewise. Fourth, for nerve pain specifically, the drugs that actually work for it, meaning duloxetine, amitriptyline, gabapentin, or pregabalin, since ordinary painkillers and opioids both work poorly for nerve pain. Fifth, the practical measures, heat and cold, weight loss, walking aids used properly, joint injections where appropriate, and pacing. And sixth, the psychological and self-management approaches, which sound dismissive to someone in pain and are not, because pain management programs have genuinely good evidence for improving function and quality of life in chronic pain. So opioids suit acute and cancer pain. The evidence does not support them well for chronic aches, and the better answers are paracetamol taken properly, topical gels, exercise and physiotherapy, the specific nerve pain drugs, and structured pain management. Let me tell you how to come off them safely because a great many people watching will be on them long term and wondering. First, and most importantly, never stop abruptly after regular use because of the withdrawal I described, and because the pain flare will convince you that you cannot manage without them. The correct approach is a slow taper, and the principle is to reduce by a small proportion of the dose at intervals, typically around 10% every 1 to 4 weeks, which sounds glacially slow and is precisely why it works because slow tapers are far better tolerated and far more likely to succeed than fast ones. Second, do it with your doctor rather than alone, and there is no rush, so if a particular step is difficult, hold at that level for longer rather than pushing through. Third, expect a temporary worsening of pain and know in advance that it is withdrawal rather than your condition returning, because that single piece of foreknowledge is what allows people to get through it. Fourth, put the alternatives in place before you start reducing, meaning the paracetamol regimen, the topical gel, the exercise program, so that you are replacing rather than simply removing. Fifth, expect the process to take months and understand that this is normal. And sixth, know that the outcomes are genuinely encouraging because studies of opioid tapering in chronic pain consistently find that most people do not experience worse pain afterward, and many report better function, clearer thinking, and improved mood. So taper slowly by around 10% at a time with your doctor. Expect a temporary pain flare that is withdrawal rather than relapse. Put alternatives in place first, allow months, and know that most people end up no worse and often better. Let me be very clear about when to seek help. Seek emergency care for very slow or shallow breathing, for extreme drowsiness or an inability to rouse someone, for blue lips or fingertips, and for unresponsiveness, all of which are opioid overdose, and note that this becomes far more likely in combination with sedatives or alcohol. Seek emergency care too for the serotonin syndrome picture with tramadol, meaning agitation, tremor, sweating, fever, muscle rigidity, and confusion developing over hours, and for a seizure. Seek same-day medical advice for new confusion in an older person taking these drugs, for a complete inability to pass urine with a painful swollen lower abdomen, and for severe constipation with abdominal distension, vomiting, or new diarrhea leaking around a blockage. Contact your doctor promptly for falls or near falls, for persistent drowsiness or dizziness, for constipation that isn't controlled, and for pain that is no longer controlled by the current dose, because increasing the dose is not automatically the right answer and the reason needs examining. And contact your doctor non-urgently but genuinely if you have been taking these daily for more than a few weeks and nobody has reviewed it, if you want to reduce or stop, or if you are taking a combination tablet and are unsure how much paracetamol you're getting. So slowed breathing and unresponsiveness are emergencies. Serotonin syndrome and seizures with tramadol are emergencies. Confusion and retention are same day, and long-term use without review deserves a conversation. Let me paint you two pictures. First picture, a woman of 78 who had taken cocodamol twice a day for about 6 years for arthritic knees. She was constipated constantly, taking a laxative that never quite worked. She'd had 2 falls in the previous year. She was foggy in the afternoons, and her family had begun to wonder about her memory. Nobody had reviewed the tablets because they were on repeat prescription and had been for years. What her review found was this: the codeine was giving her limited pain relief, which is common and may have been a metabolism issue, while causing the constipation, the fogginess, and contributing to the falls. And crucially, she was also taking paracetamol separately for headaches, which meant she was occasionally exceeding the safe daily paracetamol dose without any idea. The plan was unglamorous and it worked. She was moved to regular paracetamol at a proper schedule with a topical anti-inflammatory gel on her knees and referred for a knee strengthening program, and her codeine was tapered over about 5 months. Her pain at the end of it was no worse than before, which surprised her greatly. Her constipation resolved. Her afternoon fog lifted, and her family stopped worrying about her memory because it had never been her memory. Second, picture a man of 72 on sertraline for depression who was prescribed tramadol for back pain by an out-of-hours doctor who did not have his full medication list. Within a day, he developed agitation, tremor, sweating, and a racing heart, and was taken to hospital with serotonin syndrome. That combination is common, entirely predictable, and entirely preventable by one glance at a medication list, which is why I keep saying that the list is the single most important thing you can carry. And let me speak briefly to those caring for an older parent or partner. Find out exactly what they take and what's in it, because combination tablets are the great hidden danger here, and a person taking cocodamol plus separate paracetamol is a common and genuinely dangerous situation. Watch for the pattern that gets blamed on aging, the afternoon drowsiness, the fogginess, the unsteadiness, the falls, because opioids are one of the most reversible causes of all three. Take the constipation seriously and make sure a proper laxative is in place from the start rather than as an afterthought, and know that new diarrhea in someone constipated on opioids is very likely overflow around a blockage. Make sure every prescriber sees the full list, particularly for tramadol with antidepressants. And if they've been on these for years without review, push for one gently, because these are among the medications most likely to roll on unchecked on repeat prescription and among the most likely to be doing harm quietly. So let me draw this all together calmly. Codeine and tramadol are opioids in the same family as morphine, and they carry that family's risks, which after 70 means falls and fractures, confusion, breathing suppression, particularly in combination with sedatives or alcohol, urinary retention, and hormonal effects. Codeine must be converted by an enzyme that some people barely have, so it genuinely doesn't work for a proportion of people who take it. And tramadol has a second, antidepressant-like action that makes it interact with SSR, is to cause serotonin syndrome, lowers the seizure threshold, and causes low sodium. Their constipation is guaranteed rather than possible and does not improve with time, so a laxative should start alongside the opioid. Physical dependence after months of use is expected, and withdrawal includes a temporary pain flare that convinces people they cannot manage, while long-term use can itself increase pain sensitivity. And most importantly, the evidence does not support these drugs well for the chronic aches and joint pains most older people take them for, where paracetamol taken properly, topical gels, exercise and physiotherapy, and the specific nerve pain medications all do better with fewer harms. So here's what I'll leave you with, straight and clear. First, know exactly what you're taking, including how much paracetamol is in your combination tablet, because accidental paracetamol overdose from combination painkillers is a genuine and avoidable danger. Second, if you take these regularly, make sure you are also on a proper laxative, a stimulant plus an osmotic from the start rather than as a reaction. Third, if you take tramadol and an antidepressant or tramadol alongside anything else affecting serotonin, check that combination with your doctor or pharmacist, because it is common and it matters. Fourth, if you have been taking these daily for months or years for chronic pain, book a review and ask the honest question, is this actually helping my pain and my function, and what would we use instead, because a great many people discover on tapering that their pain is no worse and their heads are considerably clearer. And fifth, if you do come off, taper slowly, expect a temporary flare that is withdrawal rather than relapse, and put the alternatives in place first, because the aim is never simply to remove pain relief, it is to replace it with something that works better and costs you less. Pain deserves treating, and undertreated pain in older adults is genuinely harmful, but the tablets that most people are taking for chronic joint pain are, for that particular job, among the least effective and most costly options available, and there are better ones. So take care of yourself, read what's actually in your painkillers, get the laxative right, and book the review that may be several years overdue. And because tapering, alternatives, and every dose decision belong entirely with your prescriber, please treat this as a conversation with your own physician rather than a decision to make alone. Treat new confusion, falls, or inability to pass urine as a prompt call, and treat slowed breathing, extreme drowsiness, or the serotonin syndrome picture as your reason to seek emergency help immediately.